Hello, welcome back to Bendy Menopause. I'm Vanessa Weiland, nurse practitioner and founder of Phases Clinic in Washington State, where I specialize in both menopause and hypermobility care. You would think they don't overlap much, but indeed they do. And one area of overlap that I have found is endometriosis. And so I brought on Jenn Jaggi. She is a surgeon and she specializes now in endometriosis excision. And I thought she'd be a great person to fill in a lot of my gaps, being more on the medical side. So welcome.
Hi, thanks for having me.
So tell me a little bit about how you decided to specialize in endometriosis.
I guess like probably a lot of people say it was kind of a long and windy road for me.
Mm.
I did OBGYN residency, gosh, probably about 15 years ago now. I graduated in 2013. And at the time, I definitely liked the surgical aspects of OBGYN a lot, but didn't really, looking back, I think it's just a reflection of how little education we did get around endometriosis. I don't remember learning all that much about it. I ended up going to practice in New Mexico, actually in a low resource setting at Indian Health Service Hospital. I was working in a hospital that was primarily taking care of Navajo patients. And so it was full scope OBGYN. Obstetrics was a big part of it. And then in terms of GYN, it was not, I would say, like a well woman type of a clinic. We were seeing a lot of more advanced cases just because patients wouldn't present until things were really more advanced. And I originally thought I'd go there and work for a couple of years, but a couple of years turned into 5 and then almost 10. And at some point felt like, wow, if I really want to kind of focus more on the GYN surgery, this would be the time to kind of pivot. Otherwise, if I don't do it when I'm about 40, I probably won't. So when I was starting to look at GYN surgery fellowships, one of my friends from residency who knows Dr. Mosbrucker mentioned that she has a clinic in Washington called Pacific Endometriosis and Pelvic Surgery and had fellows in the past. Fellows are essentially the name of the people specializing and, doing additional training. So a fellowship would be after residency, doing more training. So I was intrigued and I came up for a week to observe her in clinic and in the OR. And I was really just drawn to what she did, the complexity of the surgeries and also the relationship she had with her patients, and seeing these patients who had really been in pain for years have such dramatic results was really eye-opening. So I convinced my husband and kids to leave sunny New Mexico to come to the rainy Pacific Northwest to do a fellowship with Dr. Mosbrucker. And now here we are 2.5 years later. I'll be finishing up this summer. And we'll be staying at Pacific Endometriosis because I found
Great.
this is
No, I hadn't heard that.
niche. And so it's in a way, it's almost like endometriosis found me. It wasn't like I kind of knew from the get-go that was what I wanted to do.
Yeah, and I hear great things about Dr. Mosbrucker's clinic. I know people travel all throughout Washington State to see her, but even all throughout the country, right?
We
Because there
get
are,
Canadian patients too.
yeah.
Occasionally patients from Mexico. Yeah, they do come from quite a distance, which I think, sadly is a reflection of just, how lacking. So in a way, it's like now I see myself still taking care of an underserved population, but in a different way.
Yeah. And, when we think of OBGYNs, we think of them as surgeons that are helping with the pelvic organs, the issues with the ovaries and uterus. And so it might surprise people to learn that you need additional training beyond that to really do endometriosis care. So can you explain a little bit about why that is?
Yeah, so OBGYN residency is 4 years. And during those 4 years, it's just such a broad number of things that you're learning about. And I think the bulk of it does get absorbed by the OB side, which is, pregnancy, labor and delivery, and the postpartum care. And I think, even looking back on my residency, the amount of time that was dedicated to GYN and specifically complex surgeries was pretty small. And I think that's only, changing more with just limitation in work hours and other things. So when people talk about an OBGYN, often it is someone who has more of a focus on the obstetric side, taking labor and delivery call. A lot of the clinics are focused on OB, or if they're doing GYN, sometimes it is the more routine, what we call like well woman care, pap smears. Certainly there are, OBGYNs who have a focus on GYN surgery, but I would say the average OBGYN is pretty OB focused. And so, on calls might be taking care of the labor floor and things that come through the ER, and occasionally have, say, an ectopic pregnancy or a torsion or something to go to the OR with. But that the bulk of the practice isn't going to be taking care of patients with complex GYN conditions like endometriosis. And so, with endometriosis, often the disease is close to the bladder, the bowel, all of these other structures that, in OBGYN training, you're kind of taught to stay away from those things. Those are someone else's territory.
Yeah.
And so the volume of surgery to really appropriately take care of patients with such a complex condition isn't there. During general training, there is, now a subspecialty fellowship called MIGS, or minimally invasive GYN surgery. And I think there it really just varies. Some programs have a lot of exposure to endometriosis, and others, it really depends on the faculty in that group. So there might be more of an emphasis on fibroids or hysteroscopy, and so it tends to be variable. And then there are people like myself who are doing more of a, what we call like informal fellowship or apprenticeship, where we're working with one person who has a lot of experience, or, it can be several person. In my case, Dr. Mosbrucker and her former fellow, Dr. Neuville, who are really focused on endometriosis. And, the longer I'm there, I realized too, I came into it thinking I need a surgical skill set, which I, certainly do, but there's also just so much in terms of understanding endometriosis as a disease, and how does it present, and where does it typically go to, and, all these things that I wasn't even aware of, that I didn't know as a general OBGYN.
Yeah, so that's a perfect segue. Just really quickly, can you define what endometriosis is?
Now we're learning more and more that it is really this complex, inflammatory disease, but specifically it's when there is tissue that resembles the endometrium in other locations, in the pelvis or abdomen, or in rare cases even outside of the pelvis, that over time can cause inflammation and pain. Primarily, or the first thing you learn about in medical school is really painful periods, which typically is the case, but it's more complex than that. You can also cause pain with bowel movements, pain with urination, pain with sex, and fertility issues as well. So as an example, like when I sometimes think back to my general OBGYN practice, if a patient maybe had been on contraceptives for years and, maybe was using the pill to suppress their cycles, then pain with their periods wouldn't be the primary thing they were presenting with, but sometimes it would be, bowel symptoms or bladder symptoms that now I recognize, those can all be endometriosis. But when someone's not having the painful period, they might get sent to a GI doc to get worked up for IBS, and then they get sent to a urologist to see if there's something going on with their bladder. And then these poor patients just go around in a circle because there's not someone to kind of put together, like, these are other ways that endometriosis can present. And sometimes I think I do think education around endometriosis is lacking, but, I think back and I'm like, yeah, as a general OBGYN, I also, wasn't aware of these things. So I try to be sensitive to, when we see patients referred in and they've been presenting to, doctors for years and just not getting that diagnosis.
Yeah, it almost sounds stranger than fiction that you have basically the lining of the uterus tissue just like that other places in the body. I've even heard of it in the lungs or in the brain or even in men, right?
Yeah, that's super rare, but there are now a couple, as was talked about, it has presented in men. Or in terms of this theory, people talk about retrograde menstruation being a cause of endometriosis, which we don't believe. But even when they've done autopsies on fetuses, there's evidence of endometriosis. So the understanding is still developing. But
yeah, and then it doesn't just sit there. It actually changes throughout the menstrual cycle, like the lining of your uterus, right?
Yeah, so that's why typically, pain will be the worst around the time of menstruation when that lining is shedding. Or, what we often see is pain around ovulation really peaks because that's when your estrogen levels are higher. And so it's going to drive the endometriosis.
Okay, so we think estrogen is the main driver.
Yeah, and progesterone is suppressive. So, again, we're a surgically focused practice, so we generally approach endometriosis through excision, but we do know progesterone is something that suppresses the biological activity of endometriosis. So it's going to make it less active and will, suppress symptoms typically. It doesn't mean that will work for everyone or that will continue to work, but progesterone does suppress it versus estrogen drives it.
Okay, and that includes the synthetic versions of progesterone, like the Mirena IUD and progesterone-only birth control, right?
Yeah, so synthetic progesterones called progestins, do suppress endometriosis and adenomyosis, and then as does natural micronized progesterone, though typically that's not as suppressive.
And adenomyosis is a lot like endometriosis, but stays inside the uterus, right?
It's kind of, some people talk about it, the cousin of endometriosis, in a way, almost like a subtype. It's when it's located within the uterus uterus itself that it's called
Okay. But
adenomyosis.
kind of like burrowing into the walls of the uterus where it
Into
shouldn't
the,
be.
yeah, the muscular part. Yeah.
Yeah.
As opposed, the endometrium is that inner lining of the uterus.
Yeah.
And then there's the muscular layer and then the outer layer called the serosa. So when it's either in the muscular layer or that outermost part of the uterus.
And we'll get to this a little bit more, but my understanding is it's a little bit easier to pick that up on imaging versus endometriosis, right?
Yeah, I guess I'll take that in two parts. Yeah,
Yeah.
adenomyosis, I mean, even when I was in residency, was really not thought about as something that you could see on imaging. Like it was kind of
Mm-hmm.
something that would be diagnosed with pathology after a
Mm-hmm.
woman had had a hysterectomy. But now, both with ultrasound and MRI, we are, realizing there are features of adenomyosis that are seen. With MRI and ultrasound, it's a little different in terms of what is being looked for. But
Mm-hmm.
on ultrasound, I mean, which is what we do in our clinic, sometimes see the cysts of adenomyosis within the muscular part of the uterus. They
Okay.
look like these little bright areas. They call them echogenic islands. Those are what we call like direct features where you're actually seeing the adenomyosis. And then there's a lot
Mm-hmm.
of what are called indirect features, like you may see the uterus is enlarged or that the top versus the bottom part is asymmetric or there's
Mm-hmm.
a curve to the uterus. So there's like 6 or 7 different features that you can look for. So we can often
Yeah.
be very suspicious for adenomyosis or even make that diagnosis based on imaging alone.
Okay.
With endo, you can. I think this is also something that's changing because people used to say you can only know that you have endo if you do a laparoscopy and you look inside. But really,
Mm-hmm.
we're in an era where a diagnostic laparoscopy is really outdated. You shouldn't be going to the
Mm-hmm.
OR to diagnose it, or at least that shouldn't be your very first step. You should really be doing thorough exam and history, and then with ultrasound or MRI, really looking for are there signs of what's called deeply infiltrating endometriosis. You're not going to see the superficial, what are called peritoneal lesions, but
Mm-hmm.
what we're now able to see on imaging is, well, for instance, endometriomas, which are cysts of
Yeah.
endometriosis in the ovary, those should be seen even if you're getting a regular ultrasound, at a general radiology clinic. But with a sensitive ultrasound, done by someone who knows what they're looking for, there's other signs of deeply infiltrating endometriosis that you can see. Rectal lesions can be seen on ultrasound, or thickening of the uterosacral ligaments, disease on what's called the torus uterinus, which is the back of the uterus where the uterosacral ligaments are coming in.
Mm-hmm.
So I would say, yes, you can sometimes see endometriosis on imaging, but having negative imaging doesn't mean that you don't have it. Does that
Got
make
it.
sense? Because the superficial peritoneal endometriosis, even when an ultrasound is done by someone who really knows what they're looking for, isn't going to be always seen. I think there's one
Yeah.
doctor up in Canada who is doing really advanced ultrasound who says he can see peritoneal endometriosis as well. I
Hmm.
think they're using some advanced techniques like putting fluid into the cavity to kind of get a closer look.
Okay.
But
Yeah. And if anyone doesn't know, I'm always very impressed by people that can read an ultrasound like the back of their hand because it's backwards and upside down.
yeah, when we in
Yeah.
clinic, I try to point out to patients what's on the
Mm-hmm.
screen. I know a lot of people say it just looks like all gray. It's a matter of doing it repeatedly and seeing the patterns. And even still, yeah, sometimes feels like a Rorschach test. You can see
Mm-hmm.
see, see things up on the screen.
So back when you were doing your general OBGYN, did you see a lot of endometriosis incidentally?
Yeah, I mean, I certainly feel like I took a fair number of patients to the operating room for, laparoscopies for chronic pain, and
Hmm.
sometimes did see endometriosis. At that point, I was also just using ablation, which is, we can
Hmm.
talk a little bit more about
Yeah.
the different approaches. But I do wonder if, it was a little less prevalent in, we know there are genetic drivers of endometriosis, if it was a little less prevalent in the Navajo population, because there were
Hmm.
certain things we saw a lot of, and I feel like we were taking a fair number of patients to the OR for other things,
Hmm.
and I certainly can recall 1 or 2 times where like a hysterectomy was turned out to be more complicated because things were adhered together, or in some cases
Hmm.
had to refer patients out to a tertiary care center. But I felt like overall I was seeing less endometriosis than when I was in Boston for residency, or I mean certainly now I have a very different patient population. So
Yeah.
almost everyone coming to see me has endo.
Uh-huh.
Yeah.
So now that you're starting to understand who this patient is, who would, what are some of the symptoms that really jump out at you is like you don't even need to look inside. You just have a really good sense that they have endometriosis.
I mean, now I feel like, yeah, so often when you're seeing someone and they're describing their symptoms, we're doing the ultrasound to kind of confirm. And I mean, certainly we're doing the ultrasound also to look for bowel lesions or endometriomas, but I feel like if someone, tells me they've since their teenage years had really painful periods, and then maybe in their 20s or at some point they also started to have more pain around ovulation, and then gradually the amount of pain between ovulation and their period also increased, and now they're to the point where they only have like one good week a month right after their period ends before that whole cycle, starts all over again. That's pretty, I would say 98% of the time that is going to be endometriosis. I mean, adenomyosis can often overlap as well, but when we hear that story, or, for instance, someone who had the horrendously painful periods as a teenager and then maybe went on the pill to suppress their periods, and now maybe when they're in their later 20s or say 30s are starting to have some of the GI symptoms or the bladder symptoms. I think that's another kind of very common one where it almost always, turns out to be endo. Or patients who maybe, what we now sometimes see is patients who maybe had even like say a hysterectomy or an ablation and the disease wasn't fully removed, and then they go on estrogen for treatment of menopausal symptoms, and then they have a flare of symptoms. So there are some things, when you start hearing the stories over and over, like pain that gets worse when they're on estrogen, or again, patients who maybe had things initially controlled with hormones, but then the symptoms start ramping up. Patients will typically, with endo, will typically say their pain is better during pregnancy. Again, not that we advocate, you hear that myth that, pregnancy is a treatment for endo. We certainly don't believe that. But if a patient says, my pain was much better with my, pregnancies, and then postpartum things really reared their head, that's pretty classic as well.
That's interesting because pregnancy famously has sky high estrogen levels.
Progesterone, yeah.
Yeah, you also have sky high progesterone.
Yeah. And I think during the postpartum period, I mean, it does sometimes make sense when you're postpartum, say someone is breastfeeding, estrogen levels are lower, and then, maybe as their cycles resume and then estrogen levels go back up. Because postpartum is hypoestrogenic. But some people only get, maybe a month or two, and then during the postpartum period, things come back with a vengeance. So there's certainly still a lot of, variety in how people present, but some of those, patterns you start recognizing, and you're kind of like alarm for this sounds like endo does go off.
Yeah, I think classically there's often a long delay to diagnosis, even though a lot of us have symptoms starting in our teens. You might be diagnosed or like in your 20s, 30s, even later. And my understanding is part of the reason is that there's a genetic factor to this. And so you're a teenager and you say, "Hey mom, my periods are, I'm going through 2 pads an hour and I'm throwing up." And they're like, "Yeah, that's that's what periods are like."
It does. There's just a lot of normalization, I think, of women's pain, and so much, is based on what, family members or other folks around them have gone through, and it's certainly, not family members trying to delay people's diagnosis, but, or I just saw a patient too long ago who had large endometriomas on her ovaries, but she said, as a teenager, her periods were painful, but not as bad as some of her, friends, so she minimized it too. In terms of, the reasons for the delay in diagnosis, I'm guessing some of your listeners have heard this statistic before, but 7 to 10 years to get a diagnosis from when patients initially presented with symptoms. I mean, it is really complex. I think some of it is, the education around endometriosis lacking. Some of it is this normalization of pelvic pain. I think it's also, there is not a good, blood test or imaging, and especially in this like high tech, medical world we live in now, like people go into the ER and they're more likely to get a CT scan before they, get a doctor to lay hands on them and take a thorough history. So I feel like people can fall into this, circle of they go in, but the ultrasound doesn't show anything, the CT doesn't show anything, lab work is going to, appear normal. And so, or they get passed from specialist to specialist, and they're all saying, well, it's not a primarily GI thing, it's not a urology thing. And sometimes at the end of the day, it does need a thorough history and a good exam. And, when we're seeing patients for a consult, we have the luxury of having 45 minutes for a new patient exam. And it takes that long, to go through a history thoroughly, to do a good exam, to do an ultrasound. But when you think back, like most OBGYNs have like 25 patients on their clinic schedule, like that just does not leave the time to be thorough. So I think that's a big component of it too.
Yeah. And so we talked about a common treatment might be some form of progesterone or synthetic progestin. When someone someone ultimately needs surgical treatment, what's the go-to there?
Yeah, so our practice is focused on endometriosis surgery through excision, and excision is different than called ablation, which is what most general OBGYNs would be offering patients. Ablation is when you go in and you use cautery to burn the most superficial layer of the endometriosis. And typically patients will get, 6, 8, maybe 12 months of improvement after ablation. They'll even, you hear of patients having an ablation and then being able to get pregnant because temporarily the endometriosis is suppressed.
Yeah.
But it tends to, recur if it wasn't fully removed. With excision, what we're essentially doing is going in and removing or excising endometriosis wherever it is found. And depending on, again, the type of endometriosis, we talked a little bit before about the peritoneal type or the more deeply infiltrating endometriosis, or endometriomas, which are the cysts on the ovaries. That does, change the approach. When endometriosis is peritoneal or superficial, we remove the peritoneum, which is that inner lining, again, in the pelvis and the abdomen. It's almost the analogy we use sometimes. It's almost like saran wrap that's coating the insides. So when you remove peritoneal endometriosis, you're removing the peritoneum with a margin and the endometriosis within it. So more, I would say, straightforward of our excision surgeries. And then when it's more deeply infiltrating, again, it can be involving the most common area on the bowel for endometriosis to be present, if it is present, is in the rectum. So sometimes surgeries for endometriosis involve removing a portion of the bowel where the endometriosis is. If it's still, relatively superficial, that can be what's called a partial thickness resection or a shaving, versus if it's a real, a larger lesion, that can require a bowel resection, which we would involve the general surgeons for those surgeries.
Okay.
Other, areas where, deeply infiltrating endometriosis often is right underneath the uterus, what are called the uterosacral ligaments. So excising the endometriosis there involves going a little deeper than the peritoneum. With deeply infiltrating endometriosis, the disease is more what we call fibrotic. It's a little more dense, almost like fibroid tissue. The other place, again, that it likes to live is very close to the ureter, which again, is the connection from the kidney to the bladder. And so the dissection to remove all of the endometriosis is tricky because you need to go deep enough to get it all out, but again, not damage those surrounding important structures. If it's bladder endometriosis is more rare, but if it were really into the muscular layer of the bladder, then a portion of the bladder needs to be excised as well with a margin, and then that can, be sutured closed.
I imagine this takes hours and hours.
Yeah, so again, there's such a range for patients who have the peritoneal endometriosis. This can be, a 2-hour surgery, but yeah, when it does involve disease that's more deeply infiltrating near the ureters or the bladder, yeah, these can be 5, 6, hour surgeries. With endometriosis on the ovary, what's called an endometrioma. Again, there, what we aim to do is remove the endometrioma fully, what's called a cystectomy, but preserve the ovary, because as you know better than anyone else, the hormones that the ovary makes are extremely important. And so it's a balance between, again, removing the endometrioma fully, but not damaging the ovarian cortex or the ovarian tissue. And that's one area too, where if a patient, a general OBGYN generally will be able to do a cystectomy, or, that is something we're taught during OBGYN residency, but with endometriomas, they can be really sticky and it can be a more difficult case. And I think a patient who has an endometrioma, if they're seeing a general OBGYN, they're at a higher chance of having that whole ovary removed as opposed to just the cyst of endometriosis, or maybe just we often read op notes where just a portion of the cyst was removed, but then it still remains. And so then there's the risk of ongoing pain.
Yeah, that's my understanding is the last 50 years or so, we've really moved away from taking out ovaries, if at all possible. I think it used to be, let's just take the ovaries out while we're in there, which, that's the same as castrating a man. It's a really big deal.
No, and the saddest cases are the ones where we see patients coming to us who have literally already had at a young age both ovaries removed to treat the endometriosis, but the endometriosis is still there. And it's like, in what other disease do we remove healthy organs, but not the disease itself? Yeah, that is one of the hardest ones. Or, a complete hysterectomy and ovarian removal, but the endo is still there. So yeah, I do think now we are at a place where, as a field, general OBGYNs are doing more to preserve the ovaries. There's been a little bit of a pendulum shift there. Even when I was in residency, if someone was having a hysterectomy, they're maybe 50, it was kind of like, okay, you're so close to the age of menopause, just take them from the perspective of decreasing the chance of a ovarian malignancy. Now
Right.
it's a much more nuanced, conversation or if even honestly when people are in menopause, but early menopause, because now we know the ovaries are still making hormones during that important time.
Yeah, and especially testosterone. That's
Mhm.
they make about half of the testosterone, and so that's one of the big differences between surgical menopause and natural menopause is that dramatic drop in testosterone levels.
Because I think it used to be, well,
Yeah.
then you can just go on hormone replacement, but that's
Yeah.
never quite as good as the ovary itself.
So we've mentioned pregnancy a couple times here. So if someone is, may want to become pregnant at some point in the future, how does that play into this whole decision around dealing with endometriosis, adenomyosis, endometrioma?
Yeah, so I mean, could have a whole hour long talk or more. It could be on the fertility side, but I think the main thing for patients to know is when they are desiring future fertility and they're coming to see us because of the pain. These surgeries can be done in a way that preserves fertility. So our goal, if there are endometriomas present, is to remove the cyst but preserve the ovary and excise the endometriosis around the uterus while preserving the uterus to be able to carry pregnancy. I mean, certainly there are, cases where the disease is really advanced, or say if both fallopian tubes, are distorted to the extent where they're not, functional. Cases where, just because of the extent of endometriosis that a patient may, not be able to conceive naturally, may need, what we call like assisted reproductive technology or IVF. But in general, by removing the endometriosis, which is inflammatory, but preserving the reproductive organs, people's chances of conceiving should be higher.
Okay.
I think, again, there's that caveat of if someone were to remove just a portion of the endometrioma and leave disease there, and then there's scar tissue, because of the disease still there and surgery, those are, the cases where often I feel like we're seeing patients who have maybe at some point already seen an infertility doctor. And I think fertility doctors always are hesitant for patients to have surgery, but I think it's because they have seen, so many cases where things were not done well. And then if you add the scar tissue of a surgery plus not, removing the endometriosis, that would not be a good combination.
Yeah.
But again, the endometriosis, we know largely because of the inflammatory part can negatively impair fertility kind of at every state, both in terms of ovulation, fertilization, implantation. So removing the endometriosis overall from a fertility perspective is a positive thing.
Okay. So that's really best practice, but ideally with someone that specializes in this so they can do it as gently as possible and get the extent of the disease
The
as best as
disease
possible.
out, but preserving reproductive structure.
Yeah, I think that's a very good takeaway. So a lot of my audience have hypermobility or mast cell activation, and it does seem like there's an interplay with endometriosis. It hasn't been totally fleshed out yet, but I guess if we just leave that aside, when you have a patient that you know is hypermobile, does it impact your surgical plan or their healing? Have you noticed anything with that?
So I would say, and we see a fair number, of patients with, Ehlers-Danlos syndrome or other things on the hypermobility spectrum. And I would say it doesn't change the surgical plan in terms of what we're going in to do in terms of
Yeah.
excising the endometriosis, but certainly it changes kind of our perioperative counseling and what we do in terms of preparation for surgery. For instance, with positioning, in patients for pelvic surgery, generally position in what's called lithotomy, which is like legs in stirrups. So taking care
Yeah.
to make sure we always do, but especially with patients who are hypermobile, the anesthesiologists, are also very careful in terms of positioning around the time of intubation. Because we know patients with hypermobility are at greater risk of injuries from not being positioned well. And then I would say when I know someone who does have Ehlers-Danlos, we also talk about how the recovery time may be, prolonged just compared to someone who doesn't have that condition. And often, we do see with a lot of our patients, fatigue is what can linger the longest after surgery, much longer than, the acute surgical pain, and that may be even more of an issue. But I would say our surgical approach is generally the same when it's more of these other, considerations. And with bowel disorder, often, just being aware of the medications, that maybe triggers, and communication with the anesthesiologist about that as well.
Yeah. And so are there any supplements that you recommend either for general surgical patients or people with connective tissue issues to help with healing the tissues back together?
I actually. That's something that if you do know of things,
Yeah.
I would need to learn more about. I
Mhm.
mean, we generally, with patients with endometriosis too, do talk about how things like diet with less inflammatory
Mhm.
factors can be very beneficial. We do see for a lot of patients like dairy and gluten are triggers, but in terms of specific supplements, I have to say that
Yeah.
when I'm seeing patients, sometimes they do have a naturopath that they're already working with who's given them guidance on that, or another specialist. So that's a little bit
Yeah.
outside of my wheelhouse, but I'm sure there are things that could be beneficial.
I think the biggest thing for any surgery is protein because your body has to
Mm,
basically create all that new tissue. And, so that's no different for people with hypermobility or Ehlers-Danlos syndrome. But vitamin C might be even more helpful in that group. It tends to quiet down the mast cells. It's really important for collagen synthesis. So, and that's very affordable, easy to come by. So that could be one of the higher impact ones for
mm.
people to take perioperatively. Are there any other things that you recommend for folks lifestyle wise or medication wise to help them prepare for surgery or post-surgical to help prevent recurrence?
I think, or just in terms of helping with their overall, recovery and decreasing pain, the one thing we always, or almost always, do recommend to patients is pelvic floor physical therapy. So
Mm-hmm.
often patients who have had, a long struggle with endometriosis or adenomyosis, the pelvic floor muscles are in spasm. And it's not that they're the primary issue, but they're kind of a downstream generator of pain. And again, sometimes getting rid of the endometriosis is enough in some patients for the pelvic floor to more fully relax. But for a lot of
Yeah.
patients who've been in pain so long, the
Uh-huh.
pelvic floor muscles have been in spasm, they do need PT to kind of more fully help those muscles relax. So I feel like I'm always, talking about pelvic floor physical therapy and its benefits with patients at their post-op appointment. I think, in terms of hormones, we certainly don't say that patients have to, go on contraceptives after endo has been excised. I know some patients have said that surgeons will say they absolutely have to. I think, then that's again a very personalized decision for every patient. There's some people who cannot tolerate hormones, other patients for whom, there can be contraindications even in terms of clotting disorders or other things.
Okay.
But we do know, again, that progesterone generally, suppresses disease activity. That's not to say that it will prevent a recurrence, but, if there is an area of endometriosis that develops, years down the line, it may be if it's a small area and the patient's on progesterone that may, suppress symptoms enough that they do not become as symptomatic. But
Mm.
again, that's a more nuanced discussion. There is that risk of recurrence. We think, it's less than I think your average OBGYN talks about with patients when they say, oh, endo will always come back, so why even go through with
Uh,
surgery? We do
mm.
acknowledge that there is a chance
Mm.
of recurrence, but, talk to patients about it more likely being in that 20% range.
Mhm.
And depending on someone's age, that really varies too. Yes, someone who's in, their late teens or early 20s, they have more years ahead of them where endometriosis may recur, versus if someone is having surgery in their 40s, the chance of recurrence is significantly smaller.
Mhm.
So again, it's not that we're saying people need to go on progesterone after surgery, because it's not been proven that that would prevent a recurrence, but it may be that if there is a small area, where endo
Mhm.
develops, that the progesterone does keep things at bay. Because it's not
Yeah.
unusual that we, maybe have a patient who had excision surgery and then a few years later, say they've had their children or at some point decide they're not planning pregnancy, then they come back and have a hysterectomy for adenomyosis. And so there are
Mhm.
sometimes, areas where there is a recurrence of endometriosis, but it tends to be very focal and not compared to the prior op note, where they may have had extensive disease, involving the uterosacrals or throughout the pelvis. It tends to be more focal where it comes back.
Okay, so not based on a wealth of data, but best practice is
Mm-hmm.
considered to add some sort of progesterone, progestin, especially if you'll have estrogen again at some point.
Mm-hmm. Yeah. Or if patients are going to be on estrogenic around menopause to treat menopausal symptoms, the newer data does suggest that kind of balancing that with the micronized progesterone is the better option. Even though,
Definitely.
like the teaching is once you've had a hysterectomy, you wouldn't technically need to be on progesterone if you were going on estrogen around the time of menopause.
Yeah, but it's not such a strong recommendation that if someone just wasn't tolerating any form of it, that you would say you insist on doing it.
Correct.
It's
Yeah.
the best
Yeah.
practice, but
Mm-hmm.
try if you can.
Mm-hmm.
And I always remind people, I'm sure you've seen more than one accidental pregnancy when someone had to improve fertility. That wasn't the reason they had their surgery. So menopause hormone therapy does not prevent pregnancy. Always throw that reminder in.
Good reminder. Yeah.
So anything else that you feel like your patients wish they had known about endometriosis before, going down this whole journey?
I mean, I think one thing when patients are coming in to see us and they've had surgery before, often they do say that they didn't really know the difference between ablation and excision, and that if they had
Mm-hmm.
understood that distinction, they would have, yeah, sought out excision from the get-go. Because again, patients, they see a general OBGYN, and, when they say
Yeah.
they can do surgery for endometriosis, I
Mm.
mean, I don't mean to put this on the patient. It's like you see a doctor assuming they will tell you
Yeah.
all of the options and, what has the best chances of the most long-term pain relief. But I think the truth is within OBGYN, excision is still not kind of what your average OBGYN is talking to patients about. So
Mm-hmm.
if a patient is considering going the route of surgery, to really ask those questions of the doctor they're seeing, especially if patient, that we were talking a little earlier about endometriomas being the one type of endometriosis that will be picked up on like a regular ultrasound that maybe their primary
Mm-hmm.
care doc ordered for them or the ER doc. And again, so if patients already know that they have an endometrioma, that is one case where it would be really important to, just to ask
Mm.
the surgeon about
Right.
their experience, because it's almost, I mean, in the hundreds of cases I've, now been involved with Dr. Mosbrucker and Pacific Endo, I can't think of one time that there was an endometrioma without endometriosis elsewhere in the pelvis. And so, if their regular
Mm-hmm.
OBGYN will go in and remove the endometrioma, but isn't addressing the disease elsewhere in the pelvis, and they're, almost guaranteed to still have those symptoms. I mean, sometimes patients aren't as symptomatic, so it's hard to, say for sure.
Yeah.
But it's pretty much, I would say unheard of to have only an endometrioma and not have some other amount of endometriosis. So if you're going to, surgery is not a small deal. So to go in, and either, I mean, we also talked about how in this day and age, a diagnostic laparoscopy is also outdated. So like the idea that you would go to surgery for someone just to look but not address the disease at the same time, it does not
A
seem
bit of a red flag.
exactly. So those would be that would be a red flag to think, is this the right person to be having do the surgery?
Yeah, and of course, people want to have as few surgeries as possible, so that's
Exactly.
why they're seeking you guys
Right,
out from all over
right.
the place.
Yeah, our goal is really, one surgery that is done well,
Yes.
not what we sometimes see patients coming in with laparoscopies year after year. And of course, there's always that risk if you have a surgery for the endometriosis that years later you will need hysterectomy, say for the adenomyosis, if those symptoms,
Mm-hmm.
become to the extent that you want a surgical intervention for that. So that certainly, is a valid reason to do
Yeah.
surgery again. But repeated laparoscopies with ablation just do not serve any purpose in my mind.
Yeah, sadly, I've had patients that have had multiple surgeries for this. So, yeah, if there's any way to just do one, that's the
Mhm.
ideal. And I guess I should say, if they're in there and you know you don't want any more kids, you can kindly ask for your tubes to be removed while they're in there.
Yeah, so doing a salpingectomy for risk reduction for ovarian cancer. Now we know that actually more ovarian cancer comes from the fallopian tubes.
Mm-hmm.
So that's a valid reason, or from the fertility perspective. And then of course, there's also in patients who have, more extensive endometriosis, there's always that question of if they're not desiring pregnancy or done having
Mm-hmm.
kids, should a hysterectomy be done at the same time? And I just wanted to
Mm-hmm.
clarify, it's not that we're recommending in those cases a hysterectomy for endometriosis, but especially if there's deeply infiltrating disease very close to the uterus, in the uterosacral ligaments and the torus uterinus, that back part, the uterus near the cervix, we do think there's a better chance of more, complete pain relief in those cases, especially if there's concurrent adenomyosis, to
Mm-hmm.
do the excision and a hysterectomy.
Yeah, makes a lot of
But it
sense.
doesn't have to be that way.
Well,
Yeah,
thanks, Dr. Yagi, for
yeah, of
coming on.
course.
Anything else you want folks to know before we sign off?
If they want, our practice is called Pacific Endometriosis and Pelvic Surgery. We do have an educational portion of our website where there's articles written by Dr. Mosbrucker. There's articles about things like adenomyosis, even links to some videos. So if patients are wanting to learn more, it's a good place to read a bit more.
Yeah, and Gig Harbor, Washington is just beautiful. So if you have to, post up somewhere for a couple months to recover from surgery. It's not the worst place.
I know patients are often surprised to hear that, yeah, a practice that's so surgically specialized would be in Gig Harbor and not Seattle.
Hmm.
But
Hmm.
but I do think there are some nice advantages too to being at a small. We operate at a community hospital called St. Anthony's, and the patients are seeing even in the pre-op area and the post-op area. The nurses are taking care of a lot of our patients, and our anesthesiologists are familiar with things like POTS and mast cell disorder, and just because it is a smaller place, and they're
Yeah.
seeing a lot of our patients, and yeah, we do not have the traffic of downtown Seattle, which is a nice
Yeah.
thing
It's
as
good to
well.
know too. All
It was
right. Well, thanks again.
great to chat with you. Bye bye.
Okay.